Hello, we're going to talk about management of macular hole with concurrent retinal detachment. First of all, we have no financial disclosures to report, and let's start with some pathophysiology. The macular hole and retinal detachment can coexist in about 0.5% of retinal detachments, and there are actually two pathophysiological scenarios that those two retinal entities can coexist. The first one is when the macular hole pre-existing causes the retinal detachment. This happens in high myopic patients with posterior staphyloma and where the hole is actually like a break. The second one is when the retinal detachment causes the macular hole. There is either peripheral break, it spreads posteriorly and stretches the fovea and creates the macular hole, or the retinal pigment epithelium and glial cells, they migrate and they create an epiretinal membrane which contracts and create a macular hole. In our first case, an 82-year-old woman with type 2 diabetes mellitus and hypertension came to us with hand motion visual acuity in her right eye, low intraocular pressure, and a macula off retinal detachment with a macular hole. Here you can see some important risk factors for macular hole. Our patient had already 3 of them at presentation, and don't forget always to check both eyes, because in about 5 to 10% within 5 years there is a macular hole in the fellow eye. Here's the surgery of our patient. After pars plana vitrectomy, we inject membrane blue dual in order to make the ILM more visible and start the ILM peeling. Now, the ILM peeling in those cases are very demanding, because don't forget that the retina is detached, so when you pull the ILM, the retina comes with it sometimes, so there are some specific tools that we can use in order to pick the ILM and start the peeling. Also, we can use perfluorocarbon liquids like PFO in order to stabilize the retina and help ourselves. In our case, we didn't. We performed successful ILM peeling without PFO, but you can see, especially here, that the retina is very unstable. After that, we performed fluid air exchange via the macular hole and fill the vitreous cavity with C3F8 20%. Here you can see 2 of those tools I've already talked about that we can use to start the ILM peeling, and also have to deal with the axial length. Here are some tips to help us deal with the axial length. What we did in our surgery was to remove the trocar. You can see that we can earn about 1.5 millimeter length just removing the trocar, and that could be significant during the surgery. Now, the second case, for the second scenario, where the retinal detachment causes the macular hole, it's a 56-year-old woman who came to us with hand motion visual acuity of her right eye, and fundoscopically, you can see here there is a macula of retinal detachment with a macular hole. In the periphery, there is a horseshoe tear about 2 hours in dimensions. The preoperative surgical plan was about the same with the previous case, plus the peripheral break sealing. Unfortunately, we lost contact with that patient, so we have no follow-up to show you. This is some highlights and the take-home message. Thank you very much.